Hi, my name is Anita Palpu. I'm one of the co-editors from Open Medicine, and we have a number of our editors here today. And we are delighted to have all of you come to hear our public panel discussion that we're sponsoring. So the title of the talk is The Power of the Public Domain. Can open or access to information transform global health? And I just wanted to give a little bit of information about Open Medicine. We're a peer-reviewed, independent, open-access general medical journal. We're all volunteers working at the journal. So if you feel inclined, we have a donation vase at that stairway. So please don't all exit on this stairway, because I just mentioned that. It's up that stairway. So if you feel inclined after the talk to give a donation, we'd be most grateful for that. And I'd also like to introduce our panel, who actually do not need much of an introduction. So the first person I'll introduce is James Maskalyk, who is an associate editor with Open Medicine. He's also an emergency department physician, and he works at the University of Toronto. And he recently launched and published his book, 6 Months in Sudan, which chronicles his experience and his humanitarian work in Abyei, Sudan in 2007. The next person I'd like to introduce is Gavin Yamey, who is a senior editor at PLoS Medicine, and he's also a consulting editor for PLoS Neglected Diseases. And he also has written extensively on global health and has held a number of writing and publication workshops all over the world. And he's a recent recipient of a global health fellowship from, is it Kaiser?
Kaiser Family Foundation in California.
There you go. And the final panel member is Dr. James Orbinski, who is an associate professor in the Department of Medicine at University of Toronto. He is also the past president who received the Nobel Prize on behalf of the Médecins Sans Frontières in 1999. And he's the founder of Dignitas International, which is an organization which works in low and middle income countries for HIV prevention and treatment. So with that, I would just like to ask each panel member to respond to the question that we posed in the title of the talk, and then I'll speak for 2 or 3 minutes. And then what we'd actually like is for the audience to ask questions. We wish we had more microphones where you could pick them up and ask, but if you can speak loudly or come down here, I'll repeat them. And we'd like this to be as interactive as possible tonight. So the first, you know what the question is, James. So can the access to information transform global health?
I remember when, can people hear me okay at the back? Okay. I remember we had a conference call about a month or so ago as we were trying to decide as editors how to frame this talk, how we can get something that the three of us that perhaps could speak to from different directions and perhaps either find common ground or reasons to disagree. But I think that we kind of gather around that idea that information can transform something as broad as global health, and perhaps it's one of the main catalysts for such a transformation. So as I was, I wrote in an editorial in Open Medicine early on that in a way to maximize its best uses, information has to be put into as many hands as possible. So that's just a statement of complete fact. If you can assume that it's to be used to maximize it, get it to as many people who can possibly use it. So that fits in well with the open access movement and open source software, et cetera. Now, when I think more about it, and I was thinking about today, about those two concepts James and I sometimes talk about, and I'm sure Gavin thinks about this too. What is global health? And for that matter, what is information and what counts as information? It's almost so vague a terms that they can become useless. But I was thinking about the truth of that statement and the truth of the statement that we framed the talk as well as in that editorial. And I'm not sure if information put into as many hands as possible, I think that's half of it in a way. I think the second part of it is to put it into as many capable hands as possible, as many people who have the capacity to use it. Because without its application, information really can't be said to exist in anything but our mind. So when I was looking at the definitions of what, the difference between data and information and knowledge, data is a a statement is an observation, a statement about an observation. And information is contextualized data. So you can put that data in a context, whether it's with other data or in an environment, to assess whether it's possibly true. So I think that what we're talking about is trying to get information into environments that perhaps something as broad as dealing with diseases that are common but perhaps unaddressed requires us to fulfill that second part of the puzzle, which is not just establishing access, but in order to find the ground where it can find purchase. So I think it gets half of the way there, but I don't know if it is the ultimate panacea or solution.
So I would like to just start by saying a little bit about the organization that I work for, the Public Library of Science. It's very relevant to what James was saying. We're an international, non-profit, kind of grassroots movement of doctors and scientists. And we passionately believe that the answer to the question is yes. We believe that the medical and science literature, that is, the research articles that report medical and scientific research, should be a freely available global public good. And we can talk about what global public goods are. Essential medicines are another. We believe that knowledge should be a global public good. Right now, about 90% of all medical and scientific knowledge is locked away behind access barriers. So if you want to read a research paper in a medical journal, typically it costs you $40 or $50. So we have a situation of enormous inequity. And when I was a medical student, one of my heroes was a family doctor in Wales called Julian Tudor Hart. He worked with poor communities, and he coined this phrase, the inverse care law, in that those people on the planet who need the most care, medical care, they get the least, right? And that is so true for knowledge right now, for medical knowledge and medical information. And with the arrival of the internet, and I'm sure that's something that we're going to talk about this evening, we have a tool that allows everybody to actually access this knowledge, and yet we're not allowing it. And I'm just going to, before handing over to James, just give you one story that illustrates this problem. And there are many, and I hear these stories every day in my work. There is a friend of mine, a professor of pediatrics in Uganda. He specializes in infectious diseases, and the World Health Organization asks him, he's called James Tumwine, he asks James to go to southern Sudan to investigate an outbreak. It's an outbreak of a disease called nodding disease. It's called that because children, they eat and then they nod off. They get an absent seizure and they appear to be nodding. It's probably due to a parasite. And so the first thing that James does before he goes into the field in southern Sudan is he wants to read every study that's been done on nodding disease to prepare himself to investigate this outbreak. But he can't. He literally can't. There have been hundreds of papers, but they're locked away. Each one will cost him $50 or $60 to read. And the whole healthcare budget of Uganda is $9 per person per year. So we have a situation in which our inability to access information, particularly in low and middle income countries, is having profound public health consequences and causing profound public health harm. The late Jim Grant, the former director of UNICEF, estimated that about 2/3 of lives could be saved if we could apply knowledge, but we have to access that knowledge first.
Okay, well, I would say that the way that the question is formulated for the evening, the power of the public domain, can improving access to information transform global health? It's a good question to catalyze a deeper question, catalyze the emergence of a deeper question, and James has already started to explore some of those dimensions. The word access, to me, although it's a word that is near and dear to my heart through the Access to Essential Medicines campaign, In this particular context, I don't think it's actually the right word. I think the word should be use. Can use of information transform global health? And I think if that's the question, I think the obvious implicit answer is yes. Access is, as James said, half of the equation. Being able to read, being able to know is the starting point to be able to ask new, relevant questions. But being able to use information and being able to be in relationship to other users and creators of data, that actually creates information and creates knowledge and creates a transformative possibility in global health and in very particular ways. And just to follow up on what James had said earlier about global health is, at least in my mind, it's a very nebulous term. It actually, for me personally, more expresses an intention than a particular practice or behavior. The forms that global health take are always very particular, very specific, very direct, pragmatic actions, operational procedures, scientific discoveries, new drugs, new diagnostics, new vaccines, new health systems, new data management systems, new clinical protocols, new epidemiologic monitoring systems. All of these things are part of the intentionality that is inherent in the term global health. And so having use to information and to data allows, having access to information and data allows one to use it. And if one is using it, and then in relationship to other users, then the possibility of genuine transformation in your particular application emerges. I would also like to say that we wouldn't even be having this discussion, not that we shouldn't or others in the world shouldn't have had this discussion at other points in history, but we wouldn't even be having this discussion were it not for the major technological transformation that the IT revolution has created. The IT revolution has created a new capacity for a new way of, in the first instance, being in relationship to others, and then secondly, a new way of capturing and sharing data and information. And I'm just going to give you a story that illustrates several important points, which I'll mention. A number of years ago, 3 years ago, in fact, 4 years ago, when we were 2 years into the launch of the Drugs for Neglected Diseases initiative, we embarked on a different approach to generating our research portfolio. Now, the DNDI, the Drugs for Neglected Diseases initiative, is a global consortia of research institutions, in fact, publicly funded research institutions that was catalyzed or created by MSF, and is focused exclusively on creating new treatments for neglected diseases in the developing world. And since we launched in 2003, we've released 2 new fixed-dose combinations, and we have a new drug, a new chemical entity that's actually entering phase 3 clinical trials for African sleeping sickness. It's that third one I want to talk about. The kinetoplastid diseases, there's a wealth of research that has taken place over many, many years all over the world. Much of that research, some of that research has been published, much of it hasn't been published. And much of that knowledge actually exists in paper form in the laboratories and libraries of many professors, many of whom are retired, all over the world. And much of that knowledge also exists in the minds of these researchers who have engaged their activity over many years. We looked at the state of the art of science, if you will, in the kinetoplastids, and particularly around African sleeping sickness. And we found just a complete shortage of real knowledge and real possibilities in terms of identifiable drug leads. So we embarked on a very different strategy for African sleeping sickness, for developing a portfolio for African sleeping sickness. What we did is we dedicated a couple of people to a couple of passionate, committed, deeply intelligent senior scientists. We dedicated them to actually going out around the world and meeting with these researchers, going through their data, sitting with them, talking with them, and trying to understand where are the holes, where are the possibilities that haven't been picked up by the pharmaceutical industry or haven't been picked up by or published in peer-reviewed journals. And in the process of doing that, we identified a whole series of possibilities, a whole series of research pathways that had not yet been properly pursued and had failed to be pursued for lack of funding and so on and so on. In the process of doing that, we identified one compound that had a very high probability of a positive outcome for our research intentions. And we did a few tests on it, a few screens, and so on. And very quickly, we now have a compound that, in fact, is entering phase 3 clinical trials. And it's a totally different strategy. Now, what the internet and what the IT revolution now allows us to do, in fact, is to apply that same strategy, but using electronic technologies and search engines and so on. And one of the major challenges now in neglected disease research is a challenge that was identified in a paper published in, oh my goodness, PLoS Medicine, neglected tropical diseases. And it's a paper that essentially describes the challenge that I've outlined in a slightly different way and suggests that the way forward in terms of actually creating a researchable and a searchable series of databases is in fact to begin with a specific kernel, as they call it, and a kernel question around a very specific unresearched area, and to create a space, a web-based space, where researchers and scientists can add, detract to that particular kernel and build from there an electronic open source database from which it is possible to generate information. And that I think is the future. And Gavin and I were talking about that's the future of the open source publishing and open source communication and research enterprise. And I think that would be something that could really change the world in terms of global health.
I'm happy to have someone ask a question. Please.
Okay, so all of that is very interesting. Now we're talking about research, and certainly we've all read many articles which say this, or one side says, yes, do this, it's a good idea, and the other side says, oh no, you have to do this. The question that begs to be asked is, well, that's a good idea. And my background is I'm also advising a project in Somalia, because what we're trying to do is we're trying to train docs in the protocols that exist today, which I think is the project area. So if we can find a way to train people in rural Somalia, be it Somalia or China or wherever it happens to be, there may be more value. So the question that begs to be asked is, in terms of open medicine and in terms of this, is there a knowledge base that you have, something that exists to say, well, instead of reading these 50 articles which we pay $50 a piece for, has somebody found the really good ones, and is that knowledge in a protocol somewhere in your databases? Or would that help?
Say knowledge translation? Is that what you're, it's a bit of a swear word kind of sometimes.
Well,
but,
yeah, so do I really want to read 50 articles if we could distill those 50 articles and say, and having done this, we've come up with these protocols that are being used in various spots.
Well, yes, yeah. I mean, you're talking about very specific applications, and I completely agree that the intent and the example you give is absolutely the right example. But I mean, we've started in the most general possible terms. But if you look, at least to me, if you look at the concrete applications of open source, either archiving or journaling, there are very concrete applications in education. There are very concrete applications in clinical practice, and very concrete applications in research, and very concrete applications in terms of public health. And public health has a whole series of subcategories, as does each of the other 3 categories. But to me, what is most interesting is thinking about this in a way that creates as many practical possibilities as possible. And the kind of thing that you talk about is one example. And I'm thinking now, for example, of blogging, around a journal article. Being able to comment on it, all of which you can do. Being able to comment on a journal article, being able to comment on a particular piece of a journal article, setting up discussion groups around particular issues, setting up, as both Open Medicine and PLoS do, doing basically user searches to figure out what this user is looking at, and matching that with what other users are looking at, and then suggesting other people who read this article. And so in that sense, you create, by using technological capacity in the most germinal way, you create a million possibilities for a billion practical applications. And it's up to the users and the networks of people that emerge around a particular issue or article or whatever, to themselves initiate a process. And I get stuff from people. I have people I communicate. I've never met with them, but I say, "Can you say, what do you think about this idea? What do you think about that idea?" And I get the same sort of thing all the time. And so, the practical form depends on the user, but the architecture depends on the designer.
Yeah, I mean, so the starting problem we still haven't overcome, right? The starting problem is that the vast majority of this valuable knowledge is locked away. You have to pay for it, and it's locked away by traditional copyright that makes it illegal for you to do creative things with it. You can't even translate this 90% of the literature. You can't create derivative works. You can't build on it. You can't put it into books. You can't make videos out of it. When you overcome that problem and you create enough knowledge that is truly open access, so you're free to read it and you're free to build on it in many of the ways that James was talking about, then some very exciting things are going to start happening. And I think that we in the open access movement, in the movement to create this public body of medical knowledge, free to read, free to reuse, we haven't yet shown what's possible, but we believe that exciting and creative things are possible. So, for example, we know that this is kind of beyond my expertise, but there are machines out there that can do data mining and text mining. In other words, if enough literature is made freely available under a progressive license, you can apply machines that can start making linkages, right? You might be looking for the next drug for schistosomiasis, parasitic disease affecting the world's poorest people. You can't read every single study that's ever published on this disease, including all the lab studies. It's impossible. Machines can start doing that for you, and they can start making these linkages. So I think that the future of this movement is about what's going to become possible. And certainly the future for us at PLoS, at the Public Library of Science, is that over the next few years, we are building what we're calling hubs, knowledge hubs, around specific issues, health issues, diseases, let's say, for example, leprosy, where you come to this hub and you find every open access study on leprosy in any PLoS journal, in open medicine, in any open access journal, and you've got scientists who are commenting on each paper, they're ranking it, they're rating it, they're uploading their own data and their case reports, and they're blogging from the field in the way that James was blogging from Sudan, the seeds of his book, blogging in the field, sharing experiences, and you've got these amazing tools and machines that can start making linkages across all this leprosy material. Then some really extraordinary things are going to start happening.
I agree. Gavin gave a great presentation today to show what one of these things looks like, and I think it does seem more and more like where we're headed as purveyors of medical information. And something I'm particularly interested in as a doctor or an editor and as a human is increasing connections. Gavin showed how you can connect this paper and this patient from this study into this asking this possible question. And the more we look how connected we are, it's clear that this is some important part of the future. Now, I'm interested in the application of the knowledge that we're talking about, and I'm still wondering about how we can make it live up to that hope of transforming global health, because we're really talking about transforming the lives of people who are sick with diseases that transcend national boundaries and have global priorities. So how does it make its way to rural Sudan or rural Somalia or Malawi, where James works? When I know very much is the case that when I was there was no internet. If there was anything, it was so slow, it wasn't useful necessarily. There was no web. So the people who were, as we look at making things that are certainly interesting, and as humans, we can create tools, and that's one of the things we are good at and we like the most. How is the next step is getting it to be accessed by people who can use it and set their own research priorities and set their own agendas? And that's something, you know, I know there's some things like, you know, one laptop per child, and there's other movements, but I haven't seen it keep pace with what we're able to do, what we figure out we're able to do with making this great idea of open access truly possible for us. Requires connection, you know, be connected.
On that, the future, and it's not the future, it's now,
Right.
And it really is now, is in mobile broadband enabled multimedia devices. And, you know, how many TVs are there in the world? How many, does anybody know how many televisions there are in the world, roughly?
I have no idea.
There's 1.4 billion televisions in the world. How many computers are there in the world? Just roughly, let's take a guess.
10%. No.
No, much more.
Really?
Yeah, 1.1 billion computers in the world. How many mobile phones in the world today?
5 billion.
4 billion mobile phones. 4 billion mobile phones today. And by 2013, it will be 6 billion mobile phones. And the two drivers for mobile phones right now are broadband connectivity and what are called emerging markets. So Nigeria, East Africa, West Africa, South Africa, the developing world. In India, there are 10 million new mobile phone subscriptions a month in India. And what's driving this is broadband connectivity. And the beauty of broadband connectivity is that it gives the user access to the net, right? To the internet. And it also gives the user or gives the owner a device where they can actually monitor, in many cases, many of their own medical conditions. So personally, obviously that could be of some use if you're diabetic or if you have hypertension or whatever. You can store medical records, all of these things. But for healthcare personnel, whether it's a clinical person or a public health person or a researcher, this totally changes the nature of the enterprise. It completely changes the nature of, and I mean it in the most specific way, the nature of being in relationship to others, and the nature of being in relationship and being able to use data and information for yourself, for your community, for your nation, for whatever. And this is now. And so that completely changes everything. But the big moral question is the question that keeps coming back to, the question of access, open or closed. Is the data open or is it closed? That's the moral question.
Yeah, it's about reframing this as a global public good.
Right.
So there's a question
here. So knowledge is the perfect public good. Perfect. If I use it, and James has used, if I use it, it doesn't make it any less valuable for James to use it, right? In fact, the more I use it and the more James uses it, the more useful that knowledge becomes, because we add to it, we discuss it, we collate it. So it's the perfect public good, and it's kind of a tragedy that we've never thought of knowledge in this way, or medical and scientific knowledge.
Go ahead.
One problem with this is you talk about use, but you're still using it in the access sense. That you, as a highly trained
I'll just repeat the question, and if you guys want to respond to it. But I don't know if everyone heard or not, but it's how can we improve the literacy of the uptake of that knowledge as part of it, but also what model, what publication can you use to express that to people so it can be used? Is that a fair question? Do you want to have a stab? I think that we're talking about different versions of trying to do that, and our colleague in the front here has mentioned another important piece of the puzzle, which is its application in particular areas. So in terms of making something, freely and widely available as much as possible to people who have an interest in answering a question can find the answer to it, I think that's what we're when Gavin's talking about hubs, that collation that makes you, as someone who has an interesting question, clinical or otherwise, increases the chance of you finding the answer. And I think when people talk about what, sometimes we talk about what's the next. Internet 2.0 has been a lot about connectivity, and somewhat the next part of it, 2.1 or whatever you want to say, the evolution, is going to be less searching and more finding. And I think that in terms of how that's going to manifest in a journal, I think it's somewhat a combination of what we're talking about today.
I think that's right. There's an organization that takes a lot of our content called AED Satellite. So they take PLoS content and they turn it into, for example, newsletters that are digested for nurses in rural Africa. So this is all going to be about local application, turning these papers into local knowledge. I quoted this statistic earlier about being able to save 2/3 of all preventable deaths by applying knowledge. And I'm not naive enough to think that the answer is simply to make journals free, because then there's all these other steps that need to happen. But you have to start by putting this knowledge out there in a way that people can then use, create derivatives and translations and so on. So in some ways, that kind of going the last mile, reaching the people in the remote villages, that has to happen for knowledge, in the way that it also has to happen for other forms of tools for improving health. So the fellowship that Anita mentioned that I'm going to be involved with over the summer, I'm looking at very low-cost, cheap, low-tech tools that we know could save lives. Bed nets to prevent malaria, male circumcision to prevent HIV, and cheap parasitic drugs. 3 tools proven to save millions of people's lives. Why are we not able to deliver these on a mass scale? Why is it that you can go to the most remote town in rural Africa and buy a Coca-Cola, but you can't easily buy a bed net, right? Only about 5% of people who should be sleeping under a bed net to prevent malaria are doing that. So there's this kind of, how do we go that last mile in all of this, in all of these tools, and including in kind of knowledge and information?
Just to follow up on that, who will pay for that? What would be the marketing model, the business model for doing that interpretation?
Yeah.
Publishers, they sell the textbooks.
Yeah. It's a great question. I mean, what's interesting is that we use a license called the Creative Commons Attribution License that allows any legal reuse, including commercial use. So you are free to take our content, turn it into a derivative like a local book, and find your own business model to sell that book. And we deliberately chose that license to kind of encourage and stimulate innovation. So,
So there's a question up there first, and then over here, and then you, okay?
Now, I might be wrong, but I don't see the closed model of information going away very quickly. With some exceptions, like open medicine, PLoS, most journals are either owned by commercial entities or they're owned by medical societies and some of those journals make tons of money for medical societies. The New England Journal makes way more for the Massachusetts Medical Society than they get from their annual dues. So why are these people going to give up a revenue source? The hard copy may be going away, but the internet stuff is still there, and you can sell the internet stuff. You sell the reprints from your journals. Why are these publishers going to give up this money?
well, they're not going to give it up without fighting, and they are doing everything humanly possible to hang on to this profit. It's about somewhere between a $5 and $9 billion industry selling content to rich people in the West. And they're not going to give it up easily, and they are lobbying. For example, the National Institute of Health, which is about $30 billion of health research a year, there's a law that was passed in the US where I live that if you get money from the NIH, you have to make your paper freely available within a year. And the publishers are lobbying to try and overturn that law. I don't think it's going to happen. I think it'll never get through the House or the Senate. We've got a new president who is very pro kind of sharing and open access and transparency. But they won't give it up without a fight. What's going to happen, though, is that just like the NIH and just like the Canadian Institutes here of Health Research and other foundations and other research funders, they are mandating that the papers that arise from their research must be made freely available. Right? If you're a research funder and you spent $300,000 or $400,000 on a study, you want that study to reach potentially 6 or 7 billion people on the planet. So you want it to be freely available. So with more and more research funders mandating that your paper has to be made available, and more universities mandating that their faculty have to make their papers available, this revolution is unstoppable. So Harvard, for example, recently passed a mandate. Its Faculty of Arts and Sciences passed a mandate. If you're a member of the faculty, you have to make your paper freely available to the world. It's great for Harvard, it's great for innovation, it's great for the world. And so there are some publishers who said, well, we're never going to publish a paper from Harvard again. We'll never let them do that. I mean, that's fine, okay? It's fine if you want to do that as a journal or as a publisher, but it's Harvard. I mean, So they're going to miss out on some good papers. And so I think pressure from research funders and pressure from academics and this movement of scientists and physicians who are saying, I spent 5 or 10 years doing this study, 3 years writing it up, and I want the entire world to benefit from my work. I mean, you do research for the public good. It should be in the public domain.
And just on that, just on a very concrete example, the culture among academics, even 10 years ago, when I wasn't an academic, was that you would publish at all costs. And the big thing was to publish in a big journal. And you would sign these copyright agreements, in many cases, without even reading them. And the imperative to publish and the delight at having your paper accepted just led you to sign anything. Now, because of this open source movement, because of the demands that are being created around the open source movement, many copyrighted journals are actually not only beginning, but are openly accepting modifications to these copyright agreements, such that you can have free use of your own data subsequently. You can republish in another setting after a certain period of time, and so on and so on. And this is something that initially copyrighted journals resisted and held on to, and said, no, if you don't sign this, you will not publish in our journal. But now with this pressure, even that is changing. It is a movement that has many different fronts. And the other key question, though, is what are the sources of revenue to sustain an open source movement? That's an important question. And is that are there sources that from the public sector? Are there actually private sector business models that can be adapted to open source journals and open source archives even, that can actually generate revenue? And there's all kinds of ideas. There's auxiliary services, there's advertising, there's add-on fees, there's what PLoS and others do, publication fees that in your case I think are accruing to the funder. Maybe you can talk about
exactly.
Yeah.
The research, when we publish a study, the research funder covers the costs of publication. Right. So publication is seen as the final step in doing the research.
Yeah.
So
I'll just use this as a chance before I forget. It's such a relief to talk about something like this sometimes as opposed to something like Sudan, which I've been doing a lot of recently. When someone asks you, what can I do? You can have some answers, that are possible. Like, for instance, publish in open access journals. If you have an opportunity to do it, you should do it. It's something that's changing, that will change with the younger populations of academics. Publish in open access journals. And the second thing I think would be to fight as internet regulation. And there's other people could be more qualified than me to speak about it, but Save the Internet is an important, you can check that out on your own, but there's what started as a very free way to share information between academic universities has become more and more into the hands of people who are trying to control bandwidth and perhaps what you see. And that's really contrary to what we're talking about today. It's the opposite of improving access. It's not. So I think those two things are two actionable points that we can all continue to prioritize.
The other thing that I would add is that what we're talking about today in kind of sharing medical and science knowledge is, I would situate it within a broader movement that is one of the most exciting movements, and James has kind of alluded to this, of recent times, perhaps as powerful and as influential as the Green Movement or even the Civil Rights Movement. It's this movement to create a body of stuff that is truly in the public domain. I think the Drugs for Neglected Diseases Initiative is a very good example, to create drugs that are considered as public goods for treating treating the disease of the world's poor. There are other sorts of movements to wrestle, to sort of pull back goods and services and products that should not be privately owned and bring them back into the public domain. There's the Creative Commons, Science Commons, Econ Port, the Conservation Commons, kind of building this kind of knowledge commons that isn't enclosed, that we all own, that we can all use, and that we can all build upon. A great example is when the World Bank insisted, as part of kind of structural readjustment, that Bolivia should privatize water. And it became illegal to collect rainwater, right? And, this is ludicrous. There was a peasant revolt and, things changed for the better. But there are certain inalienable goods and services that we should not stand for people owning. And I happen to believe that medical and scientific knowledge, this treasury that can be applied to improve global health, is one of those items, those kind of goods that should not be corporately owned. 4 mega publishing companies now own 70% of the world's medical knowledge. And you can call me an old-fashioned lefty, but I get very nervous when 4 multinational publishing corporations own this vast body of knowledge that really we should all be able to read and see and reuse and build upon and apply to patient populations around the world.
I'm wondering if there's ever been any estimates done on the cost of shifting the cost of publication from the information users to the public or to the foundations that are funding it, so that if a entire shift were to occur, the public could know how much they would have to pay, how much tax revenue would it take, and then is it worth it? And once that's established, I guess it's a matter of then engaging in a political project to convince the public and major philanthropists that it's worthwhile. And I'm wondering then, until that happens, if it ever happens, when you have a shortage of political will to do the full transition of covering the publishing costs, and you don't have quite enough volunteers doing all of the opening on all of the publications on peer review, would it be possible to do something like a market segmentation, where you have open access for only certain parts of the world that don't have the ability to pay, such as the Ministry of Health of Uganda maybe getting 10,000 access codes or something, much like you saw with antiretroviral drugs with the production of generics for certain parts of the world. I'm wondering if that's like a midpoint alternative, and what the cost you think might be if you were to do a full-scale shift financed by the governments of the Western countries.
I can answer the first question quite easily because there have been 2 studies done by the Wellcome Trust, which is the world's largest private biomedical research funder in the UK. And they found that if all subscription-based journals moved to an open access model where the research funder covers the costs, the societal cost would go down by about 30%. Right? So this is something, particularly with economies of scale, that would be excellent economically. Don't forget that right now we, as taxpayers funding universities who buy subscriptions, we're spending about $5 to $9 billion on subscriptions for journals. So it's a matter of taking that $9 billion that's already in the system and using that to cover the actual costs of creating journals and putting these papers out there. So it's totally feasible. And we're in a transition period where, you know, we haven't yet made that shift, but that shift is happening, and it's kind of, I think, unstoppable. On the second point, the WHO, the World Health Organization, does have an initiative along that kind of market segmentation idea, where some journals give some access to some papers in some very poor countries. It's not ideal, it's not perfect, and it's not the future. They only do it in countries where they literally have no subscribers because people are too poor. And the minute that anybody starts to get a little bit richer, they cut off supply. So it's sort of the crumbs from the rich man's table model, and it's not the future, but it's better than nothing.
Is that Hinari?
It's called Hinari, yeah.
And the common criticism of that model so far has been that it's focused around academic institutions where most people in the country don't work near a library. It's more, and Ptolemy is a similar project that has the same criticisms leveled at it. It doesn't reach the end user because it's tricky with IP addresses. And I think, as we talked earlier, James pointed out, as soon as you're able to have people who can really access that information and you can have it in as open as possible is when its application is going to happen.
Go ahead.
Does the panel have any strategies for getting at this incredibly valuable legacy resource? That's one part. The other part is, in light of what's happened to the recent court case in Sweden, where essentially file sharing has become illegal, perhaps. Just like interested in hearing your comments about those two questions.
I can't speak to the Swedish case. Can you tell a little bit about this?
So in Sweden, where the pirate dudes had their big file sharing server set up, and everybody was doing a big torrenting of movies, but the judgment was around file sharing. So you start sharing medical knowledge, but then it starts looking from the ISP, the technical layer, as file sharing. They're going to clamp down on it.
I think that the first part, I'll just speak briefly, but it relies on me as the author to make my work available freely. And then there's platforms, perhaps, that we can use, but I think that's the first piece of the puzzle, is that I agree that anyone can use the information that I apply as long as it's to do with the health of human beings.
Yeah, I mean, everything published in PLoS and in Open Medicine is published under a license called the Creative Commons Attribution License, so you are licensed to reuse the materials, provided you credit the authors. And that's been tested in the courts. So there was a recent case where a photograph on Flickr that had been published under a Creative Commons Attribution License, some news magazine used it, but they didn't credit the author. And they went to court, and the court declared that yes, this was a violation. It was totally legal to use it, but they didn't credit the author, and they had to. So there is some protections still within this idea of reuse. You still want to get credited for your work, but all other, all reuse, all legal reuse is allowed, provided authors have signed this license that James mentioned.
Go ahead.
I wanted to get at the legacy database.
Oh, okay.
Like all this incredible knowledge. You guys are an impressive organization. Could you put pressure to peel some of the copyright off and ease up a bit?
Go for that. There was a movement to do that 6 months after, right? Become papers published to make it freely available. I don't know the status of that, but I think that was the same, from the same spirit. Particularly for countries who are low and middle income countries.
The best analogy that comes to mind is access to compound libraries in the pharmaceutical industry, something I have some experience with. And they are commodified entities. They shouldn't be, for all of the reasons that have been explained here, but they are commodified. They're protected by intellectual property rights. And really the only way to gain access to those compound libraries there's two ways. One is to reach an agreement with the company around use, and you can get sub-licensing agreements for use in certain markets or certain non-markets is where they would likely give it to us, on the proviso that if you generate a new product or a new application, that they would have IP for the rights in the north, let's say. That's not going to be a good model for the kind of issue that you're talking about. The second way is to discuss the issue in the court of public opinion. And in discussing the issue in the court of public opinion, what it does is it exposes the moral failures that are inherent in, for example, a company keeping control of a compound that could potentially save millions of lives. And that damages a company's public image, and therefore damages the brand, and therefore damages the commodity value of anything that they can commodify or legitimately commodify in the future. And I think a similar strategy would apply here. There may be specific agreements with one of the four companies that you can work out, but ultimately this is really a question about knowledge and who owns it, and is it ours or is it yours? In, for example, universities, which are in principle, at least in Canada, publicly funded, there is already a collective political decision that has been made to fund an institution to generate knowledge and disseminate knowledge that is ours. And we as academics need to follow through on that commitment and make sure that we put our knowledge, whatever it is that we create, in the public domain. And that's part of the battle in the court of public opinion.
There's a question over there. He was waiting.
I wanted to pick up on the ideas of copyright reform. And there's been, I think, some very useful insights already, and I don't hear any of you objecting to them, except you're not thinking about them the way a lawyer does. I'm a lawyer.
The first disclosure.
So there is a potential legal solution in expropriation law, where you might think of expropriating and creating a public market out of this copyrighted information. And that's perfectly legal if you can get the legislatures to do it. And maybe you'd wind up paying. An expropriation requires you to pay. But if you're only providing access to the man who's studying nodding disease in southern Sudan, you're not going to wind up paying very much. So it might be very cost effective for the society or for philanthropists to stand up and say, okay, I'll pay for that. I'll pay for that access. So I leave it for you to think about using the policy of the law more assertively along the lines of expropriating this market and creating this public market in the public good that Gavin identifies.
You know, I know very little about law, but I'm sure James could talk to this far more eloquently than I can. But there is, within international trade law, a clause called TRIPS that allows you to create generic versions of life-saving drugs.
Compulsory licensing.
Compulsory licensing, parallel imports. So you can get over copyright or patenting or ownership in public health emergencies and produce your own generic versions of drugs. And someone once wrote to me to say, why don't you try some TRIPS-like activism around what you do and say, you know what? Sometimes we publish papers that are potentially, akin to essential medicines. Couldn't you make some kind of legal case that actually it's a public health emergency and you have a right to distribute it, whole scale, massively, I've never really followed up on that suggestion, but it's an intriguing one.
And it's a very, very good idea that you've posed. I'm not familiar with expropriation law, but I know a little bit about the TRIPS agreement and compulsory licensing and parallel importation, and that would be an avenue that you really should think a lot about. I just point out that a compulsory license also pays a royalty to the patent holder or to the copyright holder, and it's a publicly determined fair rate. And in the majority of cases, it's somewhere between 5 and 9% of the purchase price, of the set purchase price, which is usually set at cost, marginal cost, plus the cost of the compulsory license. And that's part of the compulsory license agreement. So the patent holder is still compensated, but not at market rates.
Exactly. And I want to say, and I don't want to distract the debate, because this is, I'm going to interject a political idea here. I think that it's a mistake to think that our prosperity, our innovation, our development of new ideas is not dependent on private ownership of these ideas. If you take away that private ownership, you really remove the incentive. And there's all kinds of failed states which have managed to do that, and they've destroyed their science and their industry in the process. Don't go that way. And this, what I'm suggesting to you, doesn't go that way. And what you're talking about doesn't go that way.
Right.
Because the theory of expropriation law is that the person whose property, as the Americans call it, condemned for the public good, he or she has a right to market value for fair compensation. And that's why, in this concept, it would work. It's such a small amount of money.
Right.
Because what you want to do is what Dr. Orbinski said. You only want to really put it into the capable hands. You're not talking about 6 billion people having access to PubMed articles. You're talking about 1,000 or 2 at any one time who need the information. It's not going to be a large amount of money that they're going to be entitled to under normal commercial fair market value arguments, which is all that they would be entitled to. The way you get there is you have to mobilize a political party.
But I would, just to be...
Yeah, and you have to go political with it, because it needs legislation.
Yeah. There's a few things there that I just would comment on. For me, the idea that knowledge that is generated and created in public institutions that are paid for by the public purse, that knowledge should be open source for everyone, for 6 billion people, if 6 billion people want to read it. So that, to me, is very clear. But that doesn't, I'm not anti-patent in principle. And I also want to make that very clear. There are very good, a patent is a very good tool. And remember, it's a social policy tool. It's not one of the 11 commandments. It's a social policy tool, and the nature of patents has changed from the Roman Empire to today. It's a very valuable social policy tool for creating innovation, for generating wealth, and so on. But also remember what it is. It's a guaranteed monopoly is what it is. And that is against the basic principles. It's a created exception to market forces. So, but that said, it can be a useful a tool in social policy. So I'm very much not against it. But the challenge here, in terms of open source, is to define what knowledge should all people have access to, and what is the line when when a piece of knowledge or moves into a commodity. That's the challenge. And I think what this open source movement is doing is changing the nature of that boundary. It's not eliminating it, it's changing where that boundary lies.
I just want to get a few more questions in.
Can I just answer one?
Very briefly.
Yeah. So I think that what's likely is that through these efforts, you may not, I think just by themselves, they're having an impact. And I look at the recent announcement of GlaxoSmithKline in February or March of this year to take a bunch of 700 chemical compounds that have patents on it and open it up for study for diseases.
Patents.
Yeah, exactly. and to decrease the cost of its drugs in developing countries. And I think that would not have happened without pressure from organizations like DNDi about people. I know we've all written on that subject about access to essential medicines for neglected diseases. So this is it's a push in that direction, and it will change. Maybe it'll change the New England Journal of Medicine, the way they do business. You know, and I think that just by virtue of talking about it and pushing forward in this direction, you have that real world outcome that's going to be a combination of what James was just talking about.
So, go ahead.
Thank you very much. Basically, what you're discussing, these are some of the problems developing countries are facing. I'll first give an example. Uganda, since I'm from Uganda, we faced the challenge of Ebola, and basically we didn't have any information on how it's managed. This was a new virus. You search the literature, you don't find anything, and it resulted in 90% of the cases dying off.
Yeah.
However, as information has continued to come over with time, you find that now when the country was struck with Ebola in 2007, at least they lost only 48%. The fatality was 48%. An indication that actually information can cause a change.
Absolutely.
Now, I would suggest that possibly maybe you take up the concept of multi-sectorism, whereby you combine efforts in the form of IEC, that is information, education, and communication. Since these developing countries have budgets for that, and they are strengthening that particular sector, they will be willing to support you to pass over that particular information. In addition, there will be even staff, local staff, who can translate some of the technical things into languages or printouts which can easily be understood by the target group. Thank you very much.
Good point.
And there are two countries that I would like to highlight that I think are ahead of the curve in doing exactly what you mentioned. One is Rwanda and one is Jamaica. And they have been investing over the last few years, or even decades actually, in building the infrastructure necessary, fiber optics and so on, laying down broadband, et cetera, to be ready for this revolution and to be able to kind of apply information and turn it into goods and services. And that's one of the other things about what we're talking about this evening, is that this is something that can help to lift countries out of poverty. That sharing knowledge it's a stimulus. It's an economic stimulus. I mean, there have been multiple studies that have shown that the more knowledge that you share, the more you stimulate the economy. It's one of the other great things about knowledge, not just that it's a public good, but you can turn it into goods and services, including health services. So I completely agree with that.
So Leslie, go ahead.
There's a question that's been implicit in the discussion. I want to go back actually to the first example that James Orbinski brought up about a lot of research that are not published, sitting in researchers' desk and getting a desk. I would venture that a lot of those are actually papers that were not acceptable
Exactly.
publications in a quote international peer-reviewed journal.
Exactly.
And so we do have a lot of research based in developing countries that are not getting the visibility and the kind of sharing that you're talking about. We seem to think that everything coming out of the New England Journal of Medicine is good, everything coming out of Uganda is not so good. I think open access is really a key to changing that boundary. And I just wonder if you could address those issues.
Well, I think that one of the challenges, and we're, at Open Medicine, open to submissions from anyone around the world. We had tried to have a diverse editorial board precisely for that reason, to encourage people to send us any paper on any, whether it's a clinical trial or a commentary. Truly, we value it perhaps even more than some of the papers we get from Canada. Not that that should stop anyone from submitting it, but because we know it's underrepresented in the world literature. So I think part of the challenge becomes, trying to improve that capacity. A lot of the research ethics, perhaps, that we have as a necessity for submission to open medicine or some of the methodology. I think that is slowly needs to be addressed as well too, at the level of the university with academic institutions, forming partnerships, using the internet or however it is to improve the likelihood of those papers being accepted, perhaps partnering, making it a mandate. So myself as assistant professor at the University of Toronto should try to partner with a country of low or middle income to perhaps help them through this process, and perhaps even journals like ourselves mentoring these researchers a little bit more than we do, because you're right. Sometimes it's a paper that needs a lot of work, and we send it back. But we could probably do a better job, so I'll take that as a good advice.
And the one thing I would add to that is that, this is the open source idea. It's not a static moment in time, and just as the nature of knowledge is not static, it's constantly changing. And so the way in which the form of access and use changes, the way in which it actually includes the experiences of people in Uganda, for example, whatever the question is, whether it's Ebola or around maternal child health or whatever, the more it includes that, the more it actually generates that. And the more that possibility actually becomes a reality, and a significant reality, and the more conceptions of global health are truly global, right? And that's extremely important. And then the second thing that I would say that we haven't actually talked about, and I'd really be interested to hear you guys, because you're editors, the role of the editor is critical here, and it's also critical to the market value of the service you're offering. If you have high quality editorial staff, people are more, the quality of the editor, or the specificity, let's call it, of the editor will define the user of the site or of the knowledge base that you're editing. So the more the quality, the higher the quality, or the more specific the quality, the higher the desirability. And what's beautiful about open medicine and PLoS is that they're, at least in principle, committed to quality across a broad range of editorial interests. So they have a broad editorial board. I'm on the editorial board. There's a whole bunch of, there's all kinds of people with all kinds of knowledge that are on the editorial board of open medicine. On PLoS, they've just launched a new one, PLoS 1, I believe, which is completely open to any subject matter. And what my understanding, and you should, is that they will find the appropriate editor for the subject that is, or for the paper that, or the whatever, the research that's submitted. And that creates a brand name, a brand value, a market value in the user of the site. And the higher the value, the more revenue can be generated, not from fees, but from auxiliary services, from add-on services, from all kinds of other things that can actually pay for the service and can actually encourage higher and higher and higher quality research, clinical training, education, whatever the application may be.
So I want to be mindful of the time. It's about 9 minutes before it's 8 o'clock, so I think we can entertain one or two more questions, and we'll ask the respondents to be brief. So yes, go ahead. With the scarf.
I think the question was, how can accessing information as a consumer change their own individual health? Is that?
Yeah, and I'm not talking about information that will be provided on a journal like Open Medicine. Obviously, we're not going to have consumers going online and reading academic research material. But for example, I can provide an example with
Just answered your own question for me.
In the best way.
Yeah, in the
No,
best
it's
way.
a very good
Better than
answer.
I could have done, so I agree.
Yeah.
That was going to be the lecture today, so I just wanted to raise sort of that perspective of this issue as well, taking it away from academia.
Yeah, that's good.
There's just one point that I would like to disagree with, just for the hell of it, which is that you said that patients won't want to look at this stuff that's in journals. And actually, that's not always strictly true. I mean, we're finding that patients download our papers enormously. In fact, there's a group called the Alliance for Taxpayer Access. It's about 100 patient groups around the world that have banded together to say, actually, we want access to journals and we want access to the literature. And what often happens is you're diagnosed with an illness or your child is diagnosed with an illness, and you oftentimes become more literate about this illness than some kind of general, physicians. You become an expert in your own disease or your child's disease. And so, I mean, many physicians have the experience of their patients in clinics now being armed with information, and it's really changing that kind of asymmetry of information that people are coming to clinic, more informed and more equal, which is clearly something that's powerful and that could be a great tool for, for health improvement. So yeah.
Gunter?
Now, I heard the words open source and open access used interchangeably, but PLoS is open access, but not open source, to my knowledge. So can you maybe explain why you are not making your platform open to communities?
Any day now, so the publishing platform is an open source platform. It's called Topaz. It was set up as a non-profit, a separate non-profit entity that's housed within our office, and it's an open source platform that anyone will be free to use. I'm not a tech person, so I actually can't really speak to it, but it is an open source platform. When we first launched, because we launched quickly, we didn't have time to develop our own open source platform, but we've done that now, called Topaz, and the code is being released shortly.
So does this include all the publishing tools, everything?
It's going to include everything. It's going to include everything. And Gunter, by the way, is a real revolutionary who's been very involved in this open access movement with Journal of Internet Medical Research. Is that right? JIMR. So, yeah, we owe him a big debt.
Well, a couple of questions ago, brought up a very good point about the consumer need for access to information that's usable and understandable by people, who are in that context. One of the things that we've been talking a lot tonight, or the questions have come up around business models with respect to the journal as the unit of publication, the journal as the unit of distribution of knowledge. And that isn't the only unit of distribution.
Right.
And I'm wondering where the innovation is, and I'm asking you, I would ask other scholars as well, that certainly, scientists are free to innovate to create other alternative venues for the diffusion of knowledge, other than the traditional format of the journal. One of the inherent conflicts with providing knowledge at the point of need, that is for the different types of uses that need knowledge, actual, that is usable information that addresses a need, that doesn't fit the scholarly publishing model. Those translation innovations aren't really in place. Certainly access to the larger body of literature would help, but I don't see a lot of innovation yet except in commenting and discussions and creating some problem-focused kind of hybrid journals and things like that. So the format of the information, the format of the knowledge is not always usable. It may be useful, but it's not usable to the actual end user, the person who wants to employ that knowledge. And so I'm wondering, we've been talking a lot about how to make open access work better and to open up the walled gardens of knowledge, but I think that we're also conflating knowledge with publications to some extent, which, we do, but, in some of my conversations with editors recently, I'd like to see, whether we can separate the diffusion of knowledge from the certification of scholarship, which a lot of traditional publication has incentivized and sharing, like the dark matter of the lab, such as Leslie Chen had mentioned. You know, there's a lot of papers, a lot of knowledge out there that is freely available if people knew that it was available. They knew that there was some market or some value for it, other than the journal itself. So that's my question. Are there other innovations other than the journals, or even the public library, which is a type of journal, to get outside of kind of that publishing model that we're also using?
I'll just speak to it really quickly, and you guys can. This is a different example about access to information transforming, at least the, I don't know, global health is, like I said, a bit tough, the broadness of that term. But when I was in Sudan, I was working in a rural area, no access to colleagues necessarily who are more experienced than me, and difficult access with telephone and no internet access. So I had an opportunity when I saw a patient who had, as a 3-year-old boy, came into the hospital, had never walked in his whole life, had intermittent fevers, and this rash that I'd never seen. He was alopecia in areas and skin discoloration. I had no idea. I had one textbook, Harrison's Principles of Internal Medicine, and Manson's Tropical Diseases. Yeah, it didn't really help me out. So I'd never seen anything like it before. And I was able to go to the UN, and which we're not supposed to do, but or keep our distance from them anyway. I'm just teasing. And send through the their server a picture. I uploaded it up on a blog, and pictures of this rash, and people from all over the world commented on it. And you know, I was careful to preserve the patient's anonymity, and there's really tricky ethical issues with that. Obviously, you know, that's something that can be solved perhaps with access or private, you know, perhaps some careful guidelines about that. But someone mentioned tuberculosis, which is something I thought about, but I wasn't really considering as the most likely diagnosis. And I started the child on tuberculosis treatment, and he walked for his first time a month later. So I think that there's many different applications that are outside of a traditional medical publishing paradigm that I think we can abandon that at some point. We're thinking perhaps inside this rigidness of it as a paper journal gone onto the internet, but its applications are much, much broader than that, and much more founded in the real world than that.
Yeah, and the...
I mean, you have a particular problem, you share that problem, and you have feedback on that issue, so knowledge to
But this whole phenomenon, Wikipedia, YouTube, Flickr, these are open source. These are new kind of experimental forms, not even experimental, they're very practical forms that are really breaking down the distinction between the certifier and the user. So the certification versus the dissemination. I like the distinction you point out, but even that is breaking down. And there are venues that the common technology now allows, blogging, annotations, commenting, and so on. But with broadband access, the range of possibilities opens up, and you can have, you know, online with your phone, online webcam discussions. You can show there's now a whole movement, or we'll call it a movement. There's a whole sector that's developing around mobile medical, mobile technology medical use, and where you can take your mobile phone or your small mobile device and take a picture. You can monitor blood pressure. You can do all kinds of things with mobile devices now. And the degree to which that enters into the commons is really a function of usage and utility.
I'm going to call this session to a close because I want to be mindful of everyone's time. I'd like to thank our discussants, James Orbinski, James Maskalyk, and Gavin Yamey. I'd like to thank you all for coming out tonight.